Hello everyone and welcome. Today, we're diving deep into a really critical class of antibiotics, the glycopeptides. We're going to focus our attention on two of the heavy hitters, vancomycin and teicoplanin. These are absolute lifesavers in the hospital, but as you know, using them correctly is a serious balancing act.
This quote right here really sets the stage for our entire discussion. It tells you that while vancomycin is our go-to weapon for some of the toughest superbugs, it's actually the wrong tool for more common, susceptible infections. This really hammers home the core principle of antimicrobial stewardship, using the right drug for the right bug at the right time.
So here's our roadmap. We'll start with the foundational principles. Then we'll look at the specific clinical scenarios where these drugs shine. After that, we'll get into dosing and safety and wrap up with the huge challenge of resistance before we do a quick knowledge check.
All right, let's jump right into the core principles. To really maximize the benefit of these powerful drugs and minimize the harm, there are a few rules that you've just got to live by.
For any patient on vancomycin, these 4 steps are absolutely non-negotiable. First, you have to be doing therapeutic drug monitoring, TDM. That means checking the levels in the blood. The key moment is checking that trough level right before the 3rd dose to make sure you're in that therapeutic window. Then you've got to adjust for kidney function. And you should even think about using a continuous IV infusion to keep those drug levels nice and steady.
Okay, with those rules in mind, let's get practical. When do you actually reach for vancomycin? Knowing when to use this drug is every bit as important as knowing how to dose it, because it's really reserved for very specific, serious situations.
So let's imagine a patient with a CNS drain who suddenly spikes a fever and shows signs of meningitis. If you're practicing in a place where MRSA is a real concern, or you suspect a highly penicillin-resistant pneumococcus, vancomycin is going to be part of your initial empiric therapy. You just have to cover those bases.
Vancomycin is also indispensable for those really complex heart infections. Think about a patient with an infected prosthetic heart valve. Or maybe you have a patient with endocarditis who has a life-threatening allergy to beta-lactams, like penicillin. In those scenarios, vancomycin isn't just an option, it's a life-saving necessity.
Here's another classic case. You have a patient with neutropenia, their immune system is wiped out, and they have a central line. They become septic. You don't know the bug yet, but that central line screams risk for organisms like coagulase-negative staph. Vancomycin becomes a cornerstone of that initial cover-all-bases regimen.
Now for this one, we have to completely shift our thinking. When we're treating C. diff, intravenous vancomycin does absolutely nothing because it doesn't get into the gut where the infection is. So we switch the route entirely and give it orally. This way, it acts locally, right where we need it to fight the infection. It's a fantastic example of how route of administration is everything.
Okay, so we know the why and the when. Now let's get into the nitty-gritty of how we dose this drug. And as you're about to see, the dosing and the route can change dramatically depending on the site of the infection.
What's so interesting when you look at this table is the sheer versatility of vancomycin. You have your standard IV infusions for systemic infections, sure, but then you have oral dosing for C. diff, direct administration into the peritoneal cavity for peritonitis, and even injection straight into the eye for endophthalmitis. Each one has a completely unique dosing strategy tailored to the target.
This number, 3,000 milligrams. This is a hard stop you need to remember. For intravenous vancomycin, this is the maximum recommended daily dose. Pushing beyond this ceiling dramatically increases the risk of toxicity, particularly kidney damage, without any clear evidence of better outcomes.
And of course, a drug this potent brings significant risks. So let's turn to the crucial topic of safety, monitoring, and the situations where you absolutely should not use these agents.
So the contraindications are pretty straightforward, but they are absolute. For either drug, if your patient has a known hypersensitivity, you don't use it. End of story. For teicoplanin, though, there's an important addition. Because of the risk of ototoxicity, you should avoid it in patients who already have significant hearing loss.
This list of precautions, this isn't just gentle advice. These are fundamental for safe use. You have to watch the kidneys like a hawk. You have to be aware of ototoxicity, especially if you're co-administering other risky drugs like aminoglycosides. If therapy is prolonged, a weekly hearing test is recommended. And you have to be very careful with anticoagulants like coumarins because the interaction can be significant. While a simple rash can happen, what you absolutely must be vigilant for are these severe delayed reactions. Things like DRESS syndrome, SJS, 10. These are rare, but they are devastating and life-threatening. If you even suspect one of these is developing, it's a true medical emergency and the drug has to be stopped immediately.
So let's move to our final topic, and it might be the most important one for the future of medicine: the challenge of resistance. The rise of superbugs like VRE and VRSA is a direct threat to our ability to treat infections, which makes stewardship more critical than ever. This distinction right here is not just academic, it is clinically vital. When you're dealing with VRE, you have to know the genotype if you can. A VanA strain means it's resistant to both vancomycin and teicoplanin. Your options are limited. But if it's a VanB strain, it's usually susceptible to teicoplanin. That means you still have a powerful glycopeptide option in your back pocket.
And this gets us to the heart of good antimicrobial stewardship. Vancomycin is often an excellent empiric choice, a broad net you cast at the beginning. But once you get those culture and susceptibility results back, you have to de-escalate. If that Staph aureus turns out to be sensitive to methicillin, you switch to a better, narrower drug like flucloxacillin. This isn't just better for the patient, it's essential for preventing the spread of resistance.
All right, to make sure all these key points have landed, let's just run through a quick self-assessment.
First up, you have a patient with a prosthetic joint infection, and they're going to be on vancomycin for a long time. What specific weekly monitoring is recommended to watch for toxicity?
And the answer is a weekly audiogram. You're obviously going to be checking kidney function frequently, but for that specific risk of hearing damage, ototoxicity from long-term use, a formal hearing test every week is what's recommended.
Okay, last question. The lab calls you with a result. An Enterococcus isolate is resistant to vancomycin, but it's still susceptible to teicoplanin. What resistance genotype does that pattern immediately make you think of?
That pattern screams VanABAM. And again, this is more than just a trivia question. It's a critical piece of clinical data that tells you that teicoplanin is likely still a viable option. It's this level of understanding that separates good antibiotic use from great antibiotic use. And it leaves you with a final thought. As these resistance mechanisms become even more complex, how are our diagnostic and therapeutic strategies going to evolve to keep pace? Thank you for your time.